believe there's an amendment at the desk.
Will report.
Amendment to H.R. 3680, offered by Mr. Griffith.
Chair recognizes Mr. Griffith, 5 minutes in support of his amendment.
Thank you very much, Mr. Chairman. Last year, I led a letter with 22 of our colleagues calling on HHS to develop best practices for the use of naloxone. This bill, with my amendments, codifies the request for best practices. My amendment takes bipartisan language developed by Senators Kaine and Capito, calling on HHS to develop these best practices for prescribing naloxone to patients who are at an elevated risk of overdose for opioids or heroin. This would include those who may or may not be in treatment for opioid addiction. We incorporated technical assistance in the amendment from HHS to ensure these best practices do not cause liability concerns for our medical providers. Finally, there is no new expenditure associated with the development of these best practices, as HHS would develop those using existing authorizations. It is my hope that we will add this amendment to a very good bill.
Chair thanks the gentleman. Does anyone else seek recognition on the Griffith Amendment? Mr. Sarbanes.
I just want to thank the gentleman for the amendment. It's a sound and a constructive addition to the bill, and I support it. And with that, I yield back.
Chair thanks the gentleman. Dr. Murphy, seek recognition.
Thank you. I move to strike the last one. I have a quick question, if I can, for Mr. Griffith on this amendment, if I could. I know that one of the concerns I hear from the DEA and from other providers is that with naloxone out there, obviously it saves lives, and it's been great for first responders to have this with them. A couple things I've heard has raised concerns. One, in computing actual drug overdoses, in some cases, once a person is revived from naloxone, they refuse to go to the hospital, and so those numbers are never registered in terms of drug overdose rates. I don't know if this specifically addresses that, but it's something I think we ought to be looking at. The second thing we hear is from people who are highly addicted. They actually now will push themselves further in taking a dangerous drug with this distorted belief in their mind that this near-death experience is okay because I can take this, someone will have some naloxone around, and so I can take a bigger risk with that. I just want to make sure we're, in our educational process and dealing with this, we're aware, we're monitoring those numbers to also look at the effect that this may have. And I yield to the gentleman if you have any comments on addressing those.
I think both are points that ought to be reviewed. I think we should certainly get it out there in the field and see what happens over time. I mean, you're right, there are going to be some folks who do that, but the vast majority of folks who are overdosing aren't thinking of it in those terms. And, I can't tell you it won't happen, but I do think it's something we should monitor. I think it's a very good point.
Well, I appreciate it, especially given the idea that once an addict is there, that's all they're concerned about is their addiction, and I appreciate it. Look forward to further conversations. Mr. Chairman,
Will the gentleman
yes,
yield?
you'll do, yes.
It's a fair concern, and it's something that I've looked into as we put the bill together. On your first point, I actually had the opportunity recently to be with some healthcare professionals in one of my counties who indicated that in these situations where somebody's being revived through naloxone after overdosing, what they're finding is that the family are immediately contacting health professionals to report that because it causes such alarm inside the family. And they're talking about, as part of a best practices, you might include providing information, an emergency hotline and so forth, with the naloxone so that people could immediately call and report that, so that it's, because at that point in time, that's the opportunity, the research shows, to have a person who's motivated with their family to move into a treatment program. And we understand that, just reviving somebody from an overdose, that's not the end of the process. It's really the beginning of the process. On your second question, there's a fair amount of studies that suggest that your concern, while valid, I think, is one that we recognize. There's a response to that. Naloxone actually causes acute withdrawal, which is very painful for individuals who are dependent on opioids. And it negates the purpose of taking the opioids. And there's a whole set of studies that have concluded that the availability of naloxone does not, in fact, encourage people to use more drugs or to use them in riskier ways. And those are some studies that we can certainly provide to
Sure.
you going
I
forward.
appreciate the gentleman's comments. Perhaps one of the things we can do is see if there are some practice guidelines that can be written along with this to make sure we're monitoring those, and I appreciate
I think it's a
the
good
gentleman's
idea.
concern.
Will the gentleman yield for a
Yes.
second?
Yes. Doc.
Yeah, I'd like to just say, as someone who has given Narcan or naloxone to patients in the hospital, that it is very important that, that they do go to a hospital after they've been given naloxone. Number one, sometimes one dose is not enough and they rebound. Number two, there are side effects of a naloxone. I don't have them listed in front of me, but you should look that up. There can be problems with like you said, quick withdrawal. People also can become combative, tachycardic, a fast heart rate, and other things. So I just want to, I do think the concern about, patients that don't go to the hospital, that we need to make it very clear, and as part of our training process of first responders or others giving naloxone, that it is very important that those patients go to a medical facility after they've been giving it. And I would argue, even if it's given by a family member, family members need to understand that there are risks of not going to the hospital. I yield.
I appreciate the discussion just in the last 20 seconds because I think it points up the value of having a demonstration, a program like this, because we begin to explore some of the issues that we just talked about here. And
Thank you. I yield back, Chairman.
Chair, thanks, gentlemen. Does anyone else seek recognition on the Griffith Amendment? If not, the question now occurs on adopting the Griffith Amendment. All those in favor say aye. Aye. Those opposed, no. The ayes appear to have it. The ayes have it, and the bill is agreed to. Does anyone else seek recognition on the amended bill? The question now occurs on